Now, this is a very interesting ECG. You can simply pause the video and you can try to find out where is the problem. Now, when we zoom in, especially in the chest leads, what we can see in from V1 to V4 is usually what should be the normal progression is in V1 and V2, it should be more of S predominant leads, where R should be a very minimal height, R wave, and S wave should be much more prominent. In V3, V4, what we get is R wave is almost equal to S wave, or usually R wave can be more than S wave, and in V5, V6, it is all which is always taller than S, or patient may not have S wave at all. So what we see here is we don't have any R wave from V1 to V4. That is very interesting because R wave usually suggests muscles or myocardium. So whenever there is extensive myocardial damage, the R wave height will automatically reduce because R wave is a contraction wave of muscles. So if there is no muscle, automatically there will not be any R wave. And here what we have is no clear R wave. So what this is called is all QS complex. This is all QS complex because there is no prominent R wave. So this particular patient had presented with chest pain which was there around a day or two back, and when this patient had presented, we can very easily see that there is no R wave, there is QS pattern. This is all QS pattern, and we can very clearly see that there is ST elevation. This is all ST segment elevation. This is S wave, and this is all T. So there is J point elevation, and this is all ST elevation. This is the baseline. This is all baseline, and we can see that there is all ST elevation from V1 to V4. This ST elevation is almost 1 and 2, two small boxes. Now, this very typically suggests that presence of Q wave or QS complex, absence of R wave, and presence of ST elevation in lead V1 to V4 suggests that the patient had evolved anterior wall MI because there should have been R wave, the Q wave should not be there, and there should not have been any ST elevation. Presence of symptoms, presence of ST elevation. This ST elevation could have been much more in height, but as the patient had presented later, this ST elevation is settling down. So this is a very, very typical ECG of a evolved anterior wall MI, because when we see other leads, there is not even a single Q wave. See lead 1, there is not even a single of Q. In lead 3, there is no Q wave. In lead 2, 3, or in lead AVL, there is not even a single 1 millimeter Q wave. In lead AVF also, there is not even a single millimeter of Q wave. So in limb leads, Q wave is not at all there. In lead V5, there is not even a single millimeter of Q wave. Q wave is the first negative wave after P. This is P wave. This is P wave, and it is directly starting with a positive wave, that is R wave. So there is no Q wave. So Q wave is present only in V1 to V4 with prominent ST elevation and marked ST or biphasic type of T, which is very typically seen with valence T. What we call it as valence T. Now, to call it as valence T, patient should not have ST elevation, ST depression, and patient should have normal R wave progression. And in that instances, if the patient has biphasic, which looks positive first and then negative first, this type of typical wave is called valence T. But for that, patient should not have acute, or patient should not have evolved MI. In that instances, this type of T is called valence T, and it suggests proximal left anterior descending artery blockage or thrombosis. So in this also, this ECG very typically suggests evolved anterior wall MI, To call it as MI, more than two consecutive leads must be involved. There should be ST elevation of more than 2 millimeter in two consecutive leads. Here we have uh, four consecutive leads which show involvement, and ST elevation is more than 2 millimeter, and that too in three consecutive leads, V2, V3, V4, with presence of Q wave, with presence of ST elevation, and with valence T type T wave. So this is evolved anterior wall MI with proximal LAD thrombosis. Thank you.